Hi, I'm Dr. Brian Koffman, a retired family doctor and a CLL patient myself, Chief Medical Officer, Executive Vice President of the CLL Society. Dr. Hill, can you introduce yourself, please?
Sure. Hi, my name is Dr. Josh Hill. I'm an infectious disease physician based at the Fred Hutchinson Cancer Center in Seattle and the University of Washington Medical Center. And my clinical practice and research focuses on cancer patients with infectious complications.
So, Dr. Hill, the big focus recently has been COVID, but we're not going to talk about COVID. We're going to talk about a new virus that's appeared, monkeypox. So, to start, what is monkeypox? And give us a little bit of the history on that.
Sure. Yeah. So monkeypox is a pox virus, and probably the similarly related virus that people have heard more about, at least in previous decades, was smallpox, which has now been eradicated through really successful implementation of vaccination campaigns. Monkeypox is not as big, has not been as big of an issue as smallpox was when millions of people were being infected and having a high mortality rate. Monkeypox is a related virus, kind of like the chickenpox virus as well, some relation to that virus as well, but has really been endemic or mainly concentrated in Central and West African countries. The primary host for monkeypox virus tends to be animal reservoirs. We don't know the exact animal which harbors this. It's actually not monkeys. That's a misnomer. It actually most likely comes from rodents. And occasionally we see these spillover events where the virus gets out of the animal community that it's circulating in and can infect humans. And that's led to pretty small contained outbreaks, mainly in West and Central African countries, but due to travel, sometimes those come out. But there haven't been any really large outbreaks of that, but that's the basic concept of this virus.
It's in the news now, though, because it seems to have left Africa and is spreading and is found in several countries around the world. First, how is it spread? And should this be a concern that it is spreading? Has something changed?
Yeah, thanks. Yeah, all great questions. So I guess the first question to address is how is it spread? And I think that's at the top of many people's minds and concerns is how do I avoid getting this? And so monkeypox, fortunately, is not as contagious and infectious due to the way that it's spread as something like SARS-CoV-2, which causes COVID-19. So that's a good thing, just to take a step back from that. Monkeypox typically needs direct contact with someone who's infected or an animal who's infected that has active lesions, a skin rash that's kind of very specific to this type of viral infection, that's open and actively infected that can then transmit the virus. So typically if people get it, it's through direct and prolonged contact. This can be through prolonged contact to beddings or clothing that someone who was infected has been exposed to. And in some instances, if you have prolonged, really close face-to-face contact through respiratory droplets over a relatively prolonged period of time, so more than 15, 30 minutes or so of pretty close direct contact of large respiratory droplets. So that's the main way that this is spread. As far as what's going on right now in the current outbreak,
before we get there, how are we sure of this? I mean, let me ask the question that I'm getting asked. We were told that that's how, we didn't get it absolutely right with COVID, and we found that aerosols were probably more important. Should we be waiting for the other shoe to drop on this one? Or, as an infectious disease specialist, you're pretty certain you've nailed this one. You've seen this one's been around for a long time, maybe not as prevalent, that we're not going to suddenly find, oh, it is aerosol, or no,
Yeah, I hate to put my foot down right on something like this because nothing in medicine is black and white, as you know, and there's always this gray area that, things are typically, for this virus, we think the most common modes of transmission are those that I've described. Whether or not you can get aerosol transmission of this virus has not been established really, and we don't think that that's a likely form of spread. That doesn't mean that it absolutely can't be spread like that, but based on what we know of the patterns of transmission, the fact that the outbreaks tend to be pretty clustered, and the way in which we've seen people who have gotten the infection are infected tends to be most commonly from direct contact. We're not really seeing cases like we started to learn in COVID of people that were eating on the other side of the restaurant, and we know only one person on the other side of the restaurant was infected, and implying that there was aerosol transmission or similar types of epi studies that have been done in apartment units or other buildings. So we haven't seen that pattern emerging in patients that present with confirmed monkeypox. most of those people have really had a known exposure that was prolonged and very close contact. So that's where the state of the science is right now.
Well, thank you for adding that details. And when you talk about epi, you're talking about epidemiology, or the study of how a disease spreads. So tell us a little bit about what's happening, because I think that's the concern that CLL patients have, is that this seems to be spreading in a bigger way than we've seen before.
Yeah, we're seeing in general more, outbreaks with zoonotic infections that kind of come from animal hosts and can spill over into humans. We've seen this now with Zika, we've seen it with Ebola, we're seeing it with SARS-CoV-1 and now 2. So we're seeing more and more of this, and now, of course, with monkeypox. And there's a lot of literature about why the spread of these types of infections is increasing, and it has to do with how we live in this planet and the interface between humans and animals and environmental changes and climate changes and travel and all of these things that contribute. So we are seeing these changes now, and more opportunities for these viruses to jump over into humans. And when you get the perfect storm of there's a spillover into humans and then other conditions that just allow something to spread, that's kind of when you get these little outbreaks that can then kind of turn into larger wildfires. And that's what we're seeing here. So, likely this got into someone and spilled over into a human in West or Central Africa, and there was probably some travel. And I think one of the main events that happened was that there was someone that was infected that was at a large social event and gathering, and it started spreading from there, and kind of then the dominoes start to fall. And so the main focus of where we've been seeing these infections are in men who have sex with men or gay men. And that's probably due to where the initial event just happened to occur, in someone that got infected, was at a large social gathering, and then it kind of spread from there. So that's been the main area where we've been seeing it. But this is by no means an infection of gay men or men who have sex with men. This can infect anybody. That's just where we've seen the initial cluster and the community in which it's been spreading in a pretty isolated way. Of course, this can affect anybody, and this can spill over. We're happy we haven't seen a much larger spillover, but it is circulating in many communities. It's circulating here in Seattle. We've now established that. Part of the challenge here is you only know what's circulating based on what you're testing. And we know with COVID, we were way behind the 8 ball on that. We didn't know what was circulating until we actually started testing people and looking for it. And then you kind of see that it's just the tip of the iceberg. So I think we're still in the discovery phase to truly understand how widespread this is, what proportion of people are infected. And that's going to be really critical to try to really get on top of this early and prevent further transmission. But I think we're in those early days of, we know it's circulating in a number of communities around the US and the world, and we don't have a great fingerprint on what that looks like.
Let me ask you one other question about transmission. And you mentioned this about the bed sheets. Is medical term for this is like fomites. These are surfaces. I've heard that it's persistent. Do we have to start worrying about doorknobs? And, if we check into a hotel, or, we're sitting on a chair or on a plane seat. Tell us about that.
Yeah, I think that's an extremely unlikely way to get this infection. This certainly was a big concern with SARS-CoV-2, and what you can do in a test tube and in a lab with spraying some virus on a surface and then testing it with really high sensitive tests, you can certainly pick this stuff up for a long time. It's always hard to apply that to the real world and know what is the likelihood that you're going to get infected by whatever you're picking up there. So certainly that was a concern with SARS-CoV-2. I think we've really taken a step back from that, even with something as infectious as SARS-CoV-2. That's a pretty uncommon method of getting infected. With this, it really needs to be quite direct and exposed contact with exposed skin, particularly mucosal skin. So we're talking about mouth, respiratory tract, genital area, to really get this virus, to have the right contact and the right cells that can get infected and go from there. So I think your day-to-day activities of touching a doorknob, sitting on a seat, travel, I think are really unlikely ways that someone would get infected.
So thank you for that. That's really reassuring. Tell me a little bit about, I think you've given us some tips about how to avoid it. Are there other things you want to say? And are there things that you would especially want to say to someone who's immunocompromised, like a CLL patient?
Yeah, so I think, first and foremost, as we even said with, some of these seminars talking about SARS-CoV-2, basic kind of steps to infection prevention if you're immunocompromised, as simple as just frequent hand washing, hand sanitizer, those sorts of things when you're traveling or in these high kind of exposure areas can really go a long way to prevent, this and other infections. So I think that's just kind of the 101 of infectious disease prevention. So I think that's important. If you've got contact with someone that's traveling internationally, some countries definitely do have a higher incidence of this than others. And certainly in Central and Western Africa, there's a higher concentration of this type of infection. So, those are contacts to potentially be more aware of, talk to more, make sure they're not having any symptoms. What we haven't talked about yet are the symptoms. Maybe we can talk about that next, of whether you have it. If you're having sexual contact with others, particularly if it's not a monogamous relationship or outside of a fully informed or monogamous relationship, it's important to always ask your partner whether or not they're having any symptoms, if they're sick. Certainly, if you see any skin lesions, those are things to be worried about. Typically, we think of this virus as presenting with this full body rash, kind of like smallpox, where you get these kind of chickenpox-like rash.
Like little water blisters.
Yeah, like little water blisters, exactly. And that's the way we typically think about it. But we've learned with this outbreak, it can be much more subtle. It's actually often been just localized within the genital or the genital areas, basically. So, and it's not specific. It could be another type of infection too. But if you see something like that, that's a good reason to avoid having sexual contact with other people or to have sexual contact with someone that has that. So I think the basic, conversations around that are always important. A condom, it won't necessarily prevent this type of infection in that scenario. So those are important things to think about, and just being mindful of that. The infectious period of someone typically starts when they have flu-like symptoms. That's how this typically starts, flu-like illness, which is, again, very non-specific. The majority of the time, it's going to be something else. It's going to be influenza or some other respiratory virus or COVID for that matter. But that's a good time to avoid people and say, don't come to my house, don't visit me, or I don't want to visit you if you're feeling ill. That's when someone becomes infectious if they have this. And then particularly open sores, open rash, kind of like someone that has chickenpox. We don't want someone with CLL to be around them because it's similar. The virus can live in those kind of blisters on the skin, and that's how it can be spread. So I think those are basic approaches to really trying to avoid people who are ill and be mindful of kind of how you're engaging with people and who, and just being thoughtful about that.
So can you spell out a little bit more about the symptoms? You said flu-like symptoms and the rash, or there are other things that are respiratory, GI? Give us a sense of it.
Yeah, like like a lot of viral infections, and like we've seen with COVID, you can get a whole variety of organ systems that can be involved in. With monkeypox, it tends to have an incubation period, meaning from when you're exposed to when you begin to have symptoms can be anywhere from 5 to 21 days. It tends to be on average around a week, to 2 weeks of when someone was exposed to when they might start to have symptoms and be infectious at that time point. Typically prevents with flu-like symptoms. So you can have fevers, you can have kind of muscle aches and pains, you can have sore throat. Oftentimes the rash starts in the mouth. If that's been, the mode of acquisition, it can start there. And lymphadenopathy, which means kind of swollen lymph nodes as well. That's the initial phase of symptoms. And then over a period of 3 to 4 days, that can then evolve into the rash, which, as I mentioned, classically starts in the mouth and the face, and then can spread down to the extremities and the hands and feet. That's typically how we see it. Kind of a poured on rash is kind of how we describe that. And it's kind of these circular, kind of nodular bumps on the skin that can have a fluid-filled kind of blister on top. They tend to look the same. They pop up at the same time. With chickenpox, you can see these things coming up in different stages. These tend to be kind of all at the same stage when they come up. But again, it can be as subtle as just in the genital area, one or two blisters, and that's it. So that's typically how it evolves. In severe cases, it can cause a pneumonia, it can infect the brain, it can give you a GI tract infection. Those are a little bit less common, but that's typically how this looks. And of course can involve the whole body in some severe cases. And that's kind of what we think about with the classic smallpox, pictures that we've seen from decades ago, this full body rash, but that's less common.
So for the immunocompromised, are they at higher risk? And maybe in that you can talk about, we've heard about a vaccine. Is there
Yeah.
preventatives, and are there therapeutics for this?
Yeah, no, those are all great questions. So yeah, immune compromised patients are patients with cancer on treatments and with CLL as well. We know that the immune system is just not as effective at fighting off viral and other types of infections, certainly. So I would say that immune compromised and CLL patients are at increased risk for this being a little bit more severe. The strain that is circulating kind of as part of this outbreak right now it appears to be a less aggressive strain of the two main ones that are out there, which is good. And then healthy people is pretty limited in most cases. Very rarely are we seeing these more severe manifestations of it. Certainly in our immune compromised patients, that can occur more frequently. I think we're still learning, and we haven't seen that many cases yet to really understand what this looks like. But yeah, I think the anticipation there is that you might be at increased risk to have a more severe version of the rash that can be painful. So that's one thing. Typically, these are self-limited, but you also have more of a chance that it goes beyond the skin and might involve the lungs and give you a bad pneumonia. It might involve the brain, give you a brain infection. So these are concerns, and they're real concerns that I think we need to be aware of. Which I think leads into what can you do about it if you are infected. And maybe if you want, I can talk about, what treatments and vaccines are out there.
Yes, please. Yeah.
Yeah, so that's the good news, is that we have a better starting point than we did for coronavirus, for SARS-CoV-2. So for that virus, we didn't have any vaccines when this started, and we didn't have any therapeutics or treatments that could be given at the beginning of that outbreak, and it took us a while to get there. We have a head start for monkeypox because a lot of the not a lot, there's a handful of medications and virus and vaccines that were developed for smallpox, which is close enough in relationship to monkeypox that they can work for monkeypox as well. So that's the good news. So there's a handful of oral and IV or intravenous medications that have efficacy we think would work to prevent, severe symptoms or treat someone who has bad monkeypox. None of them are specifically approved for the treatment of monkeypox, which means that it's a little bit challenging to get access to them. So there are drugs available, and they're kind of controlled by the FDA and the CDC now, primarily for smallpox. So if we want to access them for monkeypox, it just requires a little bit more of logistics to get them. But I think in an immunocompromised patient who falls ill with this and is hospitalized, we can get them. I don't think they would be indicated in your run-of-the-mill. Even if you have CLL and you've got this and you're doing okay and you have a couple spots, I don't think we would go to that extent, because there are side effects to these medications as well. But in a tough spot, we do have these, which is good to know. There are vaccines as well, and those can be used for both pre-exposure prevention. So if you're in a high-risk scenario, or will be, we can give that to someone to prevent the chance that they acquire this infection. And we can also give them as post-exposure prevention or prophylaxis, meaning you've got a known or a high likelihood of a high-risk exposure, we can get you vaccinated to prevent the chance that you get this infection. So those are two approaches. Right now, as far as giving it preventatively, I think most people that will probably be listening to this call likely won't fall into the category of people that we're considering. I think our understanding of how prevalent the virus is right now wouldn't suggest that all immunocompromised patients should get this vaccine like it did for SARS-CoV-2. Right now, it is being recommended in certain populations, like men who have sex with men, who we've seen the outbreak focused in right now, people working in labs with samples, or other people that would otherwise, healthcare providers that are seeing patients with this might want to get it preventatively. Anyone who has a known exposure and is high risk, I think, should, in the CLL population, look to get a vaccine that can reduce the risk that it goes and spreads beyond an initial infection. And then finally, there are immunoglobulin infusions. So these are antibody infusions that some people might be familiar with, like IVIG. There's other types of antibody infusions, and there's a specific one that can be given also as post-exposure prevention in this context. So it's a little bit of the lay of the land. Those vaccines are somewhat limited in access and how to get them, but I think we're working through that to make them more available as needed.
are the vaccines, like smallpox is a live vaccine, are these vaccines safe in CLL patients? Because we've been told not to have live vaccines.
Yeah, absolutely. So yeah, there are 3 different vaccines that are out there with variable access in the US at least. One of them is a live vaccine, which we would not want to give an immunosuppressed patient due to the risk that that could actually replicate and cause some more problems than good. One of them is an attenuated version of the virus, meaning that it can't actually replicate. And so it doesn't pose that same risk. There is one available that doesn't pose that risk that can be given to patients and has been used. So I think that's the good news.
Well, we've covered a lot of material. Any final thoughts or any advice you'd give to your CLL patients specifically, or cancer patients in general, about the risk of monkeypox? It's really a crazy time we're living in.
Yeah, it's definitely a crazy time and a stressful time for people whose immune systems aren't, working at full capacity. I think the individual risk to someone out in the community right now with CLL going about their daily life is probably pretty small. I think we still need to do a better job of uncovering the extent of spread. I think in New York City, it's higher than in most other places. And so if you're living in New York City, you might want to be on higher alert. And of course, it also depends on what your lifestyle is, what kind of exposures you have. And so I think for, most of our patients with CLL, a lot of our patients are, living longer, active lives. And so you're out there doing your thing. So I think just understanding what your risks are and your exposures, kind of based on what we talked about earlier on in this, can help you, fine tune how you approach things. But I think the basic approach to, keeping your hands clean, keep it, washing when you're around people, avoiding people who are ill, will go a long way in preventing this infection and others as well.
Dr. Hill, thank you so much for this. I think this was very clarifying. I think it had the right amount of reassurance and precautions. I'm deeply grateful, and let's stay in touch because this is obviously an evolving situation. Thank you so much for sparing time to do this. So appreciate it.
Perfect. Always a pleasure. I hope that was helpful.
Extremely helpful. Thanks.